Thank you all, welcome, and thanks for joining us today. This webinar is part of the Ask About Asthma campaign week. Focusing on some issues pertinent to primary care. So thank you all for joining. For those of you who have not heard about Ask About Asthma, so Ask About Asthma is a campaign that's been running in London for the last 5 years, and this year, importantly, has been picked up at national level, held in week 38, which is the week at which we see these kind of peaks in asthma exacerbations presenting in emergency departments and general practice. And it's about raising awareness of asthma in children and young people. We have 3 main asks from the Ask About Asthma campaign to highlight. One is encouraging children and young people to make sure they've had an asthma review in the last 12 months. Also that they have a personalised asthma action plan, and that within the last few months somebody has checked their inhaler technique to make sure that it's appropriate. So that's what Ask About Asthma is. There's plenty of information about the activities that have been happening over the course of this week. So today is the last day of the campaign week. One of my colleagues is going to post a link in the chat. If you want to have a little look at what else has been going on, there are other events that have been recorded, lots of blogs and stuff like that. So you can access and have a little look in your free time if you want to see what else has been happening over the course of the week. So without further ado, we're going to move on we're going to start with just some etiquette. Please, cameras off, and cameras off for everyone. It just saves bandwidth, and keep yourselves on mute during the course of the presentations. If you do have any questions that you hear during the course of the speakers' presentations, we're not going to do the raised hand option. If you have a question that you would like to put to our speakers, please just put it into the chat. I will keep an eye on that, and we'll ask those questions. We'll pose those questions to the speakers at the end of their presentation. So that's how we'll do it. And just to let everyone know, this session is being recorded, and a link will be available on the Healthy London Partnership website with any slides if you want to have a little look or share with friends later. So let's get on with things. So if we so our first speaker today is Errol Gaillard, who's a pediatric respiratory medicine consultant at the University of Leicester, and he's going to be talking to us about some interesting work around asthma reviews in primary care. So with that, Errol, over to you.
Thank you very much for that introduction, and welcome everybody. My name is Errol Gaillard, and I'm a respiratory paediatrician working in Leicester, and I've been working across with primary care for a number of years, and I will be showing you this afternoon what we found with enhanced primary care annual asthma reviews. And I have no conflicts relating to this presentation. To understand the problem, it's really crucial that we understand the size of the problem, because only once we understand that will we be able to take the appropriate steps to make things better. So the first half of the talk is about the size of the problem, and the second part is about potential solutions. So just over 1 million children in the UK receive asthma treatment. That's Asthma UK data, and it's roughly 3 children in every classroom. And respiratory paediatricians and Asthma UK feel that despite these numbers, children in the UK are not receiving the attention it deserves, and that is supported by a number of reports that keep coming. I put this one up because it's probably less well known. It's from the Nuffield Trust, that is an important NHS think tank, and it's basically a report from 2019 entitled International Comparisons of Health and Well-being in Adolescence and Early Childhood. And the report has a number of key findings. I've highlighted the one that is relevant to asthma, and it's about number 5 on the key problems. And it states here that the highest asthma death rate for those aged 10 to 24 among all 19 countries, apart from Australia, New Zealand, and the United States. And that's illustrated on this slide here. So if we leave Australia, New Zealand, and the US off, that are at the bottom here, and focus on our European neighbours, then you can see that the problem is huge. Our death rate in children and young people with asthma is higher by a several-fold change compared to other countries. And this is not all just Southern European countries, so it's not that Portugal and Greece that are at the top here have a very favourable climate and maybe less asthma, but there are countries on there such as Finland and Sweden that are further north than us. They have the same damp and cold climate, but their asthma outcomes are much better. And in fact, I will briefly talk about Finland because they had a very big asthma campaign. So this data is supported by WHO data, and this is data from 2006 to 2015, the latest available report from the WHO, and it's again about asthma death in children. And you can see to the very left of this graphic is Great Britain, and this has the tallest bar by a long shot. And again, as you move along to the right, you can see other European countries, including Sweden, that on this particular chart has the lowest mortality. Whichever way you look at this, the UK and Great Britain is not doing well. And so it's often felt that asthma deaths are the tip of the iceberg as far as asthma management is concerned, and this further graphic illustrates this. So the Global Asthma Network, again the latest report available, shows that UK children have the highest risk of an asthma attack of any other high-income country in Europe. So that supports the finding there is very high rates of asthma attacks, and resulting from this, some children don't make it, and therefore we also have a high mortality rate. And this graphic is a little bit fuzzy, sorry about that, but the United Kingdom is shown again with a red arrow from the GAN report, and you can see we're not doing well. This is a comparison between the 2001-2005 and then a repeat survey 2011 to 2015. And you can see most countries, including the UK, have improved, although the UK has only improved a little, and in the international comparison is not doing well. I did say I was going to talk about Finland, which is 3 countries above the UK here, and you can see that on the 2001-2005 graphics, Finland is scoring very high. Finland, a bit like the UK, has had a big problem with asthma attacks and asthma death in children and adults, and they have done a big national campaign. We haven't got time to go into this extensively, but they increased asthma education, and they improved or put a lot of investment into primary care asthma reviews, and that has paid huge dividends. And where Finland was once one of the worst performers in Europe, now that they are now one of the best performers in Europe. And I think they show very clearly what can be achieved if everybody is working together to improve asthma outcomes. They're a fantastic example. So this is from the NHS 10-year plan. The NHS has also recognised that there is a problem. 1.7 million children have long-standing illnesses, including asthma, and the NHS, a 10-year plan, acknowledges that England lags behind international comparators in important aspects of child health. We couldn't agree more. So what's currently recommended for children with asthma. We have the NICE 2017 asthma guidelines recommending objective tests, including spirometry, bronchodilator reversibility, and FeNO testing, also peak flow variability, to diagnose children and adults with asthma. I'll focus on children, so I will not always mention adults, but so this is from for children from the age of 5, and this has been supported by the asthma quality standards, and standard 1 is objective tests, and then written personalized asthma action plans, asthma control monitored every year at every asthma review, and that people with an asthma attack should be reviewed in primary care within 2 working days. This is the NICE QOF template for primary care, and it reflects some of these recommendations. Register patients with asthma. I'll come on to that. That is a problem. And variability or reversibility recorded. This is of the lung function testing, so supporting objective tests. And then the patients that receive an asthma review, the annual asthma review in primary care. And finally, there's a recommendation on smoking status, and that's very important in younger children. The exposure to cigarette smoke is a massive stimulus for the airways and leads to poor control and asthma attacks. And of course, as the children get older and become teenagers, they may pick up smoking themselves. What is the situation? Well, the NICE guidelines clearly have not been implemented. They have not been implemented in primary care, and they've not been implemented largely in secondary care. And the NICE asthma quality standards have only been partially implemented. And we know that 60%, for example, are not receiving basic asthma care, which should include the asthma quality standards. And this is recent Asthma UK data. And the report from Asthma UK stresses that the situation is worse in children and young people. And we know, of course, that the National Report of Asthma Deaths, published in 2014, made 19 recommendations, of which 1 has been partially implemented. So how are we going to make this better? Because GPs are already struggling to manage the workload in primary care at the moment, given the COVID pandemic, and this is not likely to get better in the near future. And here a report by Mark Levy, who was the lead author on the NRAD report, Pediatric Asthma Care in the UK, Fragmented and Fatally Fallible. It's a very nice summary. And again, my last slide on the current state of affairs from Asthma UK, the 2018 report. We talked about the 60% young people not receiving a good level of care, the variation in care across the UK, and that we need to do a lot better. So I'm going to present some data from a Leicestershire initiative, the Champions study, and we worked with 10 practices around Leicestershire on enhanced annual review asthma reviews, implementing NICE guidelines and NICE quality standards. And this is the map to see where they're located, some inner city, some county, and some further the Kettering way, so a little away from Leicester, but not too far. And this was really an implement.
Errol.
Yes.
Hi, Errol. Sorry to interrupt. Just to give you a time check, you've got 5 minutes if we want 10 minutes of questions.
Okay, doke. Thank you. Thank you. So this was an implementation study, and the aim was to study whether spirometry and FeNO could be done in primary care. We recently published the time-needed training requirements, and we studied children aged 5 to 16 years. So some of the headline figures already on this slide. So this included 612 children. So this was not a small study, and highlighted in the yellow is children not on the asthma register. This is children prescribed asthma medication, but not on a register. And you can see 156 patients were not on the asthma register. And this despite the GPs already moving some of the children before the study onto the register. And the number of children who had unscheduled healthcare visits for wheezing in primary care were as high, if not higher, in children that were not on the asthma register. And they, of course, don't benefit from the annual asthma review. This slide shows the variation in asthma diagnosis, and this is the 10 practices, A to J, and in the red box is the number of patients on the asthma register. I hasten to say this includes adults and children, but you can see quite a lot of variation from 3.6 to just over 8%. And we think that the prevalence of asthma in the UK is around 10%. And in the purple here is the practices with the lowest coding for asthma, and the box below shows the deprivation index, and you can see there is a 1 and the 4. So these are children living in some of the most deprived areas around Leicestershire, and the lowest number here on the asthma register. So I do worry about these children. So is it feasible to do spirometry and FeNO on a group of children that have not done this before? And this graph shows FeNO in red. Acknowledge FeNO is more difficult because of the technique used. By the age of 8, nearly 100% of children able to do this. And spirometry often felt to be difficult, but with relatively minimal training, 80% can be achieved at the age of 5 and 100% by the age of 8. This is definitely feasible. What our data shows is if this was done as part of the asthma review, we found about a quarter of children with abnormal lung function in the red box, and at the bottom 5% of children with very severe airways obstruction. The asthma control is measured at each asthma review, and it does not predict spirometry or FeNO. In this table, there is poor control and children indicating, or families indicating, poor control. In fact, about half of them have normal spirometry and normal FeNO. And maybe more worryingly, those children report good control. Only about half have normal tests. So the outcomes of the enhanced review, we found that the mean number of unscheduled healthcare visits fell by approximately 30% in the 6 months following the review, and the total number of children, or the proportion of children, fell by 28%. So these reviews can be effective at reducing asthma attacks and improving asthma control. I'm going to skip over a little bit of the adherence data and just present the Leicester adherence data. This is a key slide that brings us neatly to the end. Adherence to Preventive medication, including inhaled corticosteroids, is very poor. And you can see on this graphic that 29 of 49 children in this study took less than 50% of their inhaler prescriptions for inhaled corticosteroids. And this is children, even though some of them in that middle section have poor control. And this is one area I would recommend primary care focuses on, is to look at prescription data, look at SABA prescriptions. They shouldn't have a lot of those, and they should pick up their inhaled corticosteroids. That is the key to success. So my conclusions are asthma outcomes in UK children is poor, and good quality asthma reviews really have the potential to improve asthma controls and outcome. FeNO and spirometry is possible to do in a primary care setting, but probably best done through asthma hubs in the future. And please be aware, and you probably know this already, adherence to inhaled corticosteroids is poor and needs to be discussed with the families. Thank you for listening. Ready for questions.
And absolutely bang on time as well. Thanks so much for that, Errol. So yes, we've got a few questions that have come through. For those of you who want to ask questions, could you put it in the chat, please, rather than raising your hands? We're going to do it. We're going to do it through the chat. So I do see some hands up. So please, please type in the chat. So some questions that we have. First one: do you think similar results would have been seen if the age range had included 17 to 24-year-olds?
Is that results with respect to so the feasibility of spirometry and pheno would be very good in that age group. The key is so one of the things is teenagers start to engage less with asthma reviews, and we know that. So they are a group that I think probably more can be achieved if the asthma review is pursued, because these people tend to step away from medical management. So, does that answer your question? I think that would be a good group to work with, because they become independent and they fall through the net. So I think better results even in the older teenagers and the young adults.
Great. Yes. So helpful. And I think where and in terms of importance, where do you think this process, this kind of idea of physiological testing and the importance of physiological testing sits in terms of importance when compared to kind of other issues around engagement, adherence, that sort of thing? So, as an example, coarsely, you can only do physiological testing on somebody who turns up. So, what are your views around that?
Yeah, a complex. I would say in a bullet point format is that we're probably underusing these tests, and performing tests would reinforce with the parents, because that's who we engage initially with, that this is an important topic. And what happens at the moment seems to play down the importance of asthma, and there is a belittling of the condition very often, and that it gets better, and that sends the wrong message at the very beginning. So I think doing these tests has a lot of added value over and beyond the test results. It tells the parents that this is important, it's an important condition. It allows the physician to explain the condition based on test results where they are abnormal, and get the family on board with the asthma treatment, and particularly the preventer treatment that is so important to keep control up and attacks down.
Great. Yes. Thanks for that. So there's a sort of theme. So there's a question in the chat, and I think probably will link into a further question. So the question in the chat was around what's your view of using PFR reversibility where we cannot refer to spirometry locally? And then I'm going to kind of lead a kind of further question after that, which will be around the kind of practicalities of this approach, the availability of spirometry, physiological testing. So if we start with that question about PFR reversibility in the absence of access to other investigations.
So yeah, it is part of the NICE guidelines, and there is objective evidence. So the problem with peak flow reversibility testing, so what doesn't work is a one-off in the practice. For that there is no data. So doing a peak flow, then giving salbutamol and repeating the peak flow 15 minutes later, for that approach there is currently no evidence and no data. But sending the child home with a peak flow diary where they enter this for 2 weeks, it has to be a short period of time but long enough to give meaningful data, so 2 weeks, and then reviewing the diary can be effective. I'll be honest and say most of these diaries are not returned, and therefore they're not that practical, but where it can be done is good. Now, going on to maybe better tests, spirometry and bronchodilator reversibility. I'm of course conscious that we haven't got the infrastructure to do this at the moment, and there is neither time from the GP side nor the practice nurse side, but we need to get to a point where we're able to do this. And I think NICE have suggested asthma hubs, and personally my experience would be that's the way to go. Have certain areas around CCGs or ICSs, whatever they're called now, that perform the testing, where there are people that are trained to do this on a daily basis. That to me is the key to success.
Yeah, and I think, just a technical point. Would you mind stopping screen sharing? If that's
I'm trying to, but I may have to come out completely because my computer. Let me just see. It's a good point.
No problem if it's too difficult.
A few things down. I will get there eventually. I can see the red box.
That's okay. All right. Don't worry. I don't want to use up your valuable time on this, Aaron. Not a problem. We'll do that when we move on to the next speaker. So I think it's certainly the logistics is tricky. I think if we don't have access to these investigations for diagnosis, having them available for kind of reviews is the next step, I think. What are your views around the a question from the chat about an important issue about where investigations sit in terms of making diagnosis. So it's possible to have a normal spirometry in a child who is asthmatic. So where does this physiological investigations sit in terms of diagnosis?
I know it's a big problem, but so my and I managed to stop the screen sharing, I think. But so conscious that the sensitivity of spirometry is not great, maybe in the region of maybe 20 to 30%, but specificity is really high. Now the problem is, and this is an important logistics problems where I think the hubs can help. What happens at the moment is child presents with asthma symptoms. They're then referred to, say, call it secondary care. They're seen months later when they're well, because asthma is a variable condition. They have tests then and they're normal. And then what do you do? Or the same could happen in primary care. The absolute key is to test children when they're symptomatic, and adults really, because if you have a symptomatic person sitting in front of you that you think, I think this person probably has asthma and may have a mild exacerbation, but their lung function is normal and their FeNO is normal at that point, then I think you can be reasonably confident that asthma may not be the diagnosis. So it's the use of the test at the right time, I think, is a crucial factor that hasn't been maxed out.
Yeah, agreed. And your thoughts on initiating treatment in somebody who clinically presents as asthmatic, but you don't have access to the investigation straight away, or the investigations seem to be coming back as normal. What are your thoughts about delay in treatment in that?
I would advise against starting treatment. Clearly, first of all, there's a safety issue. Okay, somebody who has an asthma attack and who is acutely unwell, they need treatment. Somebody that presents with symptoms, but it's not entirely clear, I would advise against a trial of treatment. And that has been found by NICE. I recently chaired a European task force on asthma guidelines in children, and we found the same thing. And so the task force recommends against the use of of treatment without investigations, because very often, it doesn't quite, the patient doesn't really fully engage with this if they haven't been given a diagnosis. And secondly, these children often remain on the treatment despite the fact that it's clear they're not responding, and because they don't attend. There's many reasons. A trial of treatment is a poor way of managing asthma, despite the fact that it's the most commonly used.
Right. I mean, I think I'd love to talk more about that point, because I think certainly from a primary care perspective, you know, in terms of access to investigations in children who appear symptomatic, we would definitely go for a different approach, which would be something a bit more pragmatic, with trial of treatment. So I think there's definitely a counter to that position. Be interested if it does crop up in Will's presentation. Errol, thank you so much. There's lots more. There are plenty more questions to talk about. I'm sorry we don't have sorry we don't have more time to go through that. Very grateful for you coming along today, and for sharing this this really you know, this interesting, thought-provoking piece of work. So we're going to move on to our next presenter, who has now joined us. Yes, so I'd like to welcome Will Carroll. He's a consultant paediatrician, honorary reader in child health at RCPCH. He has very many other strings to his bow also, and it's delighted to have him with us today. Will, over to you. Oh, and are you sharing your own slides, Will?
No, I thought I could request control of the screen. Can I do that?
No, we can show them for you, or you can put your own up. So we can
show them for me, and I'll just do next slide, please.
Next slide, please. No problem.
So Fantastic. I'm going to pretend I'm Boris. Isn't it Boris who says that? You know, I mean, I just need a platform. Chris Whitty. Next slide, please. John Van Tamp. Next slide, please. Vin Divica.
So we'll share the slides, and if I could ask you, Will, just to keep an eye on your time, if you could wrap up within 20 minutes, so we can have 10 minutes for questions at the end. Thank you.
I'll do my best. You know, the key thing about being an expert speaker is that you learn that if you run over with your slides, you've got less difficult questions to answer. Surely that's the point. I'm going to tell you today about the 5 things I wish I didn't know about asthma, and about inhalers. I mean, there's lots of things I wish I didn't know, and these are the uncomfortable truths, the things that you find out that you go, oh, goodness me, I wish I didn't know that. Next slide, please. And just for those who want to fall asleep for the rest of the presentation, this is it. These are my 5 things. Patients, even those we know really well, are going to lie to us. If there's anyone on the call who you're deluded if you don't think that's not the case. The only inhaler that's going to work is the one that the patient can and will use. And there's 2 parts to that, aren't there? The third is that PMDI and spacer is the most reliable system of delivery. I wish I could let you off the hook and say you can use what you like, you just stick it in your mouth, because the patients would be delighted with sticking it in the mouth. But
you should listen to this.
And number 4, everybody hates steroids. What is it? Everybody hates Chris? Everybody hates steroids. Doesn't matter who they are, they all hate steroids. Well, maybe I don't hate steroids, but I think I'd hate it if I was a patient. And fifth, the most difficult and unfortunate, uncomfortable truth at the moment is that PMDIs, I'm afraid, might be contributing to climate change. So the world is burning and it's all my fault. So those are the 5 things I wish I didn't know. And actually, by the end of this talk, you're going to know them. So you can share my pain. So over the next 30 minutes, what I'm going to do is I'm going to share some stories that I've got. There might be some twists in the tale. And I'll tell you that the best mistakes to learn from are other people's mistakes. So maybe you can learn from my mistakes, and then we'll have 10 minutes, I hope, for questions. Next slide, please. So before we start, I think I want you to think about what are the 4 biggest issues you face when meeting a child or family with asthma. And I put up my big 4. And they're about getting the diagnosis right, understanding whether the child and parents are taking the medicines, how they're taking it, the family dynamic, and the treatment. These are the 4 things I want to consider. But really, if there was one thing that was the biggest issue that faces me in clinic, it's adherence. It's all about adherence. It's not about clever biologics. It's not about some groovy test. If we can get the patients to take the medicines in the right way at the right time, more than 3/4 of the time, most asthma is really well controlled. And I'm a happy man because my asthma admissions go down and I look great. So really, it's all about the adherence. One of my favorite papers ever is from my friend Paul Brand. And he said he's got a paper entitled, It's the Adherence, Stupid. Now, you're not allowed to get that published in journals anymore because they want the title to reflect the content. But actually, it's just brilliant. Look it up. It's The Adherence, Stupid by Ted Clock and Paul Brand. What a brilliant title for a paper. Surely the journals need a sense of humor again. I've got a 5-stage approach when I see patients in clinic, and it's about getting to the truth. And I think Errol's just talked a bit about that. It's asking the right questions, checking the inhaler technique. I'm doing a clinic right now, and all morning I've been checking inhaler technique and getting the lung function, the exhaled nitric oxide as well. And then for me, it's about thinking what else might be going on. I don't think I've seen a single patient actually with just asthma this morning. They've all got asthma plus something else, and working out what else is going on is really important. The thing that I do for most of my patients is to share those higher expectations. And then I do a trial of treatment because I make a change and then I see what's happened. And when all else fails, I phone a friend. So that's my approach. Next slide, please, to pediatric asthma. But I'm going to tell you some stories. I promised some stories, so here's some stories. I'm going to tell you about Jack. Jack presented to me at the age of 6. He had a wet cough and he had right middle lobe chest infection. I don't like the P word, but had an X-ray and they were changed in the right middle lobe, so you can use the P word if you want. But he wasn't really infected. It felt like asthma, and he did have salbutamol responsiveness when he was seen in hospital. And I did some background checking, and the background checking showed that he had an elevated IgE, and he also had skin prick test positivity to house dust mite. And I started him on Seretide, and he got better. So yeah, I sort of gave up at that point. I thought, well, it's completely well now on Seretide, done my job, and I kept on seeing him in clinic. Next slide, please. And I saw him for a long time. I really got to know Jack well. He was about 13, but he was never completely under control. When I went through the symptoms, he was never completely under control. Never bounced back into hospital. His FEV1 bounced around 75 to 95% predicted. He had a few flare-ups and needed some steroids, but 2 or 3 each winter, and he stayed out of hospital. I mean, I think, I'm a hospital doctor. He wasn't bothering my ward, but he was on a reasonable amount of treatment. He was on Seretide at 125, Montelukast, short-acting. He was on some cetirizine as well. So, he was, next slide, please. So he was, requiring some treatment. And then he came up to my clinic at 13, and at this stage, I was doing exhaled nitric oxide on all my patients, pretty much every visit. And his exhaled nitric oxide was 132 parts per billion. So I've got you all to think now, because you're reading my slide. It's a best of 5. So there's a single best answer here. What is the most likely cause of Jack's elevated exhaled nitric oxide? Lots and lots of possible answers. Feel free to put them in the chat if you want to. If you want to guess, just type a letter in if you want to. What is it? Is it going to be eosinophilic esophagitis? That's the one at the top there. Excellent. I like this audience. I like this audience. You're absolutely right. Next slide, please. He's not taking the treatment. Now, I've written some papers. This is like one of my least read papers ever. Feel free to take the link down and click on it, and then at least 2 people will have read it in the entire world, talking about tailored therapy for children with asthma, personalized medicine. Pulmonary Therapy 26. I'm pretty certain it's still open access. Yeah, it probably isn't, but it probably is. Have a read. Lots of causes of exhaled nitric oxide, but not on my list, not in my own paper, is the main cause of elevated exhaled nitric oxide. It is that they're not taking their treatment. Next slide, please. So this is my thoughtful face. I'm thoughtful though. Oh, Julie, is he? This is Julie. This is meet mum. This is Jack's mum. This is actually Jack's mum. I have permission to use these pictures. So this is Julie. I said, Julie, how often is Jack using his inhalers? And she says to me, well, he's doing it himself now. I sort of looked at Jack, and Jack looked at me. Jack looked at his shoes a bit, and I said, how you doing with your treatment, Jack? Oh, it's going all right. And it became fairly obvious fairly quickly in the consultation that Jack had been lying to me for, God knows, I don't know, 3 years, 4 years, 5 years, however long he'd been doing it himself, he'd been lying to me. And it's a really interesting question. Why would patients lie to us? I think that in children, there's a range of things. Some of them are a bit ashamed. They come to clinic. I mean, Jack liked me. He didn't want to admit he wasn't taking his treatment. You know, Jack's seen me lots of times. He's like, Jack's my mate. He's not going to tell me he's not doing what I expect him to do. He quite likes me coming and saying, oh, you're doing a great job, Jack. Well done. He might be a bit embarrassed, you know? I mean, frankly, when I go to the hygienist at the dentist and they ask me, have I flossed? I don't know how many people on this call are thinking, well, I've been asked that question. You know, there's something we do around that as well, isn't there? Because we know when we go to the dentist and we're going to go and see the hygienist, that actually the week before we go to the dentist, we floss twice a day like we've never flossed, in the hope that we get away with it. I mean, in the absolute hope that somehow my gum disease will have got better by doing flossing for a week. So, you know, we've all got that sensation of, yeah, we're embarrassed if we're not doing what we know we should be doing. There might be a fear of being told off. Maybe I'm not really that strict in clinic. I mean, anyone who knows me, I'm not that strict in clinic. But there might be some of you a bit strict in clinic. You know, oh, I'm going to get told off if I tell them I'm not doing my treatment. And then there's this a genuine phenomenon that I absolutely believe, and I coined this phrase with Paul Brand, which is the reverse placebo effect. And that is where the patient tells you they're doing what you asked them to do to please you. The reverse placebo, pleasing the doctor. Of course, I'm taking my treatment, Will, and I'm miles better. You're a wonderful doctor. That literally, we all fall into that trap. Next slide, please. I'll tell you what was happening with Jack, and it's very obvious with hindsight. This was a paper published in 2008, around the time I was seeing Jack, and it shows the age at which patients take responsibility for their asthma treatment. Very specific, this is about asthma treatment. When a child is 6, 7, 8, 9, it is the parent who is taking responsibility for the treatment. And when they are 11, 12, 13, they start to take more responsibility and parents encourage them to do so. And at that point, you've got to really watch them. There's actually a dip on this slide at just after they enter high school, where they're supposed to be taking responsibility, and they were doing when they were in primary school, and then they're a bit distracted by secondary school and they've stopped doing it. And we all recognize and see that. And this is there in the data. It's published in Pediatrics. Have a read. It's a great paper. So it is parents who determine adherence in younger children, and in older children, it's the child. Next slide, please. So discussion, education, prescription. There are 3 components to any inhaled prescription. You've got to get the drug right, you've got to get the device right, and you've got to get the instruction right. So this is a reminder about how to use it. In the chat, feel free to put it in there. How should we use a dry powder device? Use some words, just any words, 1 or 2 words, 3 or 4 words, not a full description. I don't want the right breathe stuff. I just want to know what words you would use to describe how to use a dry powder device. It's like Vinnie Jones. It's Vinnie Jones. It's Vinnie Jones. Vinnie Jones uses these words. He says something over the sovereign, doesn't he? On the you save a life, hard and fast over the sovereign. So yeah, thank you, Felicity. Fast and strong. Next slide, please. Fast and strong is the key for dry powder. So here are the basics, and this is the most basic of basic instructions on how to use a dry powder inhaler that I could find. And there are some things that you need to do in there. The first is open and activate, or remove the cap if there's a cap on it. The second is breathe out, and they don't breathe out. Then it's bite and seal, because otherwise it lands on your teeth. And then it's fast, sharp inhalation and hold. And it works really well. But you need to tell them every single time you see them. And, you know, the amount of suck you need depends on the device. And actually, for most of my patients, they can't use dry powder. If you ask the experts, and we've asked the experts in asthma about this, they say, how old do you have to be before you can use dry powder? And I'm sorry to break your hearts. It's 12. And DPI is always, it's never going to be better than PMDI and spacer. There's something else that's cool to know about dry powder devices, and that is that what you're doing with the dry powder device is you're needing to give energy to disagglomerate. Oh God, I can't say that word. Basically, to break up the dry powder. And if you don't do that and don't give enough energy, it's not going to be delivered because it's not going to disaggregate in the way that it should. So you need a device that's relatively high resistance with lower flows. So children actually need relatively higher resistance devices. And they may be able to use it on the day you see them in clinic. But I think you've got to be aware of the Barocca effect. If you see them on a really good day and they can do it, that does not mean that they're going to be able to do it on a bad day, on a day when they're feeling a bit rushed and a bit tight. Are they going to be able to use their dry pad device? So you be really careful in children that they might be able to, at 7, show you brilliant technique with a DPI in clinic, but are they going to be able to sustain it? And what's the worst time to stop your medicine? You get a cold, you're not feeling so well. Should we stop your asthma meds? I don't think any of us would suggest that's a great plan. So let's be really careful with DPIs. I'm going to tell you a story. Next slide, please. You see, Edward was 8. He taught me a lot. He was admitted to my intensive care unit, stroke HDU, when I was in Derby with life-threatening asthma. And he had been recently changed to a dry powder device. And he had good technique, and it seemed to be going really well until he went to Grandma's house. And he went to Grandma's house and he wasn't so well, and there was dust in Grandma's house and some pets, and he couldn't activate it. And the only reliever he had was a blue dry powder reliever. Couldn't use it. Severe attack. Mum and dad, he ended up being blue lighted. He was really quite sick, close to the edge. And mum and dad on HDU, understandably, very anxious. And they had brought the stuff in. And even better was that they managed 2 mistakes for the price of 1. So I bought 1 and I got 1 free with Edward, because I looked at his volumatic on the unit and I took 1 look at it and went rattle, rattle, and it didn't rattle. And the reason it didn't rattle is because they'd broken it so badly. The valve had completely fallen out. It wasn't even in there. So the valve was missing. So I had to do some re-education. You know, the only thing better than education is re-education. This comes from basically the only thing better than writing is rewriting. I edit a journal, I write a few books, and the only thing better than writing is rewriting. So the only thing better than education for your patients is re-education and re-education and re-education. Every visit is an opportunity. Re-educate. And for the PMDI and spacer, next slide, please. There are 6 essential steps, and they're really easy. Take the caps off and shake. Fit to the spacer. Chin up. Exhale. Bite and seal. Breathe and press. And then you may breathe entitled breathing, or you may breathe as a single breath technique. The choice is yours. Depends on the age, how good they are at following the instructions. Younger children, we tend to use tidal breathing. Older children, we move to single breath because it's a little bit quicker and they like the speed. But that's it. That's how you use a PMDI spacer. What could be simpler? 6 steps, okay? And 6 trigger phrases. I'm going to talk to you about a final patient, Joanna, who taught me something. Now, this patient's a really interesting patient because she's a conglomerate who was made into an actress. And I've got loads of video of Joanna. If people have seen me talk before, you might have seen the videos of Joanna. And the story is she's only picked up 2 Preventive inhalers in the last year. Now, we've all seen this patient. Next slide, please. And I have a long chat by video with Joanna on the ward, and I actually do it. I do it in role play, and I don't pick up anything. And then she has a long chat with my clinical nurse specialist, who also role plays in role, who works out that Joanna's problem is that she thinks that the steroids will give her spots and stop her growing. And do you know what? That's such a common belief in teenagers. It really is. They're all worried about the steroids, and that worry translates into worse control. take my own research on this. We look, those parents who report that they're still concerned about steroid medication are much more likely to have very poor control. Much more likely. And the worry then persists. Next slide, please. The things that we can do that will modify patient behavior for the older children or parent behavior for the younger ones is to address these concerns about medication, talk about them, get them out in the open, and at the same time demonstrate the necessity for the medicine. Get the pheno. If it's high, that's going to help. It helped my discussion with Jack. Get the lung function. That's going to help. If the lung function is an obstructed loop and you show salbutamol reversibility, you can talk the patient through that. Get the control test scores, either the childhood control test or the asthma control test. So childhood asthma, CACT or ACT. Get that information. It's really important. Next slide, please. My last uncomfortable truth before we get to the credits is that PMDIs contribute to global warming. They contain global warming pollutants, GWPs, and they make a small but significant effect climate change. Unfortunately, there are no alternatives for younger children at the moment on the market. And whilst for adults, DPIs have been sold as the preferred solution, and even the RCPCH have come out and said, maybe we should use DPIs. These are not going to be suitable for the vast majority of the patients in my clinic, certainly not until they're over 12. And only then, if they can sustain it on a good day, is it them on a good day? Can they still use their DPI? And we're still going to need to prescribe spacers and relievers to allow them to manage an asthma attack, an acute exacerbation. Next slide, please. That was one of my clinical nurse specialists, by the way. I didn't realize she was stage and screen there. She just walked straight in the background. Okay, proves I'm in clinic. Okay. Look, minimizing climate impact. What can we do? Excellent paper by Omar Osmani. Excellent paper. Improve asthma control. Correct the technique. Make optimal use of spacers. Ensure that there's a PMDI and spacer for emergencies, and ensure that PMDIs aren't being thrown away when they're, when PMDIs are got rid of, that they are recycled if possible. Although that's very difficult at the moment. I'm trying to start some discussions with companies about getting those programs for recycling started up again. But most importantly, something that I've learned is teach patients how to recognize when inhalers are empty. Do you know how to do that? Well, I'll leave that hanging. Next slide, please. Minimize waste. Use a spacer, use it properly, use devices with those counters where available to keep track, talk to patients. Next slide, please. So here are my 5 things. I told you what they were at the beginning. I hope you remembered at the end. The patients will lie to you. The only inhalers that work are the ones that they can and will use. PMDI and spacers are the most reliable system of delivery. Everyone hates steroids, and you've just got to talk about it. I'm afraid the next challenge is what we do about climate change. And that's a challenge that faces all of us. Time for questions. Thank you.
Fantastic. Thank you so much, Will. That was awesome. I think the climate change one might take slightly more than the 7 minutes that we have left available to us. So there was a comment in the chat. I think it was a more specifically actually about an older patient, about an adult patient, but I suppose the point is relevant. So it was a question about a patient saying they don't get on with their physically couldn't utilize the inhaler. In this frail elderly patient, it was because the patient said it was just too big for them to use. But I guess it's a relevant point to discussion about inhaler choice, I think.
So, it's the right device for the right patient. There are definitely some people who can't actually press down and they're on the PMDI to activate it if they've got very arthritic hands. But I mean, I'm not an adult doctor, but there are going to be people who can and can't use dry powder devices. There are going to be people, a lot of elderly people really struggle in the discussions I've heard about it with different devices. And my hidden slides were the things that people get wrong. And that was a study in COPD and the mistakes that people make with inhaled devices. Never cease to amuse me. when you go through clinic and you chat, if you just want to be amused of a day, just make sure you check how they're using their devices, because I've seen it all. And when you think you've seen it all, then you see something else. It's absolutely, I've got stories, but they'd use it at the question time. So get me some more questions and I'll not tell you all the stories about how I've seen inhalers misused.
So one, it's in response to your question that you left us hanging. How do you tell people to recognize when their inhalers are empty?
They've got to count. And there's no easy solution. There are apps that help with counting, but the bottom line is you've got to cross it off as you're using it and know how many doses. I've spoken to the MHRA this week about getting the labeling on the front of packaging and inhalers themselves much clearer about how many doses are in this, and then making it clear that they need to count down if there's no counter on it. Now, that's a big ask. Now, I guess if you're paying for your own prescriptions, you might be motivated to not waste it. But for those who don't pay for prescriptions, maybe they don't care, but they should care, because one Ventolin inhaler is 175 miles of car journeys. So you can get on your bike all you want, but if you're going to throw your Ventolin away when it's half empty, that's a big problem.
Yeah, it's a big ask. I think much easier with the regular meds, because you can tell them how many days or weeks it should last. But for the PRNs, definitely a trickier.
If you care a lot about it, use a medicine with a counter. Yeah. We do have scope to choose. Don't always choose the cheapest if you care about the environment. And there's loads. We could do the environment all day about the different types. I would like to see something that goes on top of the inhaler, the PMDI, that counts each time you press it. And there are some devices that sort of do that, but are more complicated around adherence monitoring. But just a really simple one that, like a little clicker when they've counted people on the aircraft and they're going like that. Just putting that on the top of the PMDI, click every time you use it, click, and then resetting it when you've emptied it. You go, it's gone down to 120. Then it's gone up to 120. I've counted 120 times. It's not rocket science, is it?
No, I mean, exactly. Okay, how about the issue about telling the truth? Have you got any tips that you could share with us on how to help that?
So turn your back on the parent, look the child in the eyes, engage them in consultation, refuse to let the parent into the consult for about 3 or 4 minutes, and then ask the child before their parent can react. So I'm having a nice little chitter chat with a young person, and they like me, and they say, yeah, I'm not using it. And mum's face, they then shoot them the most evil look, and then they're in big trouble, like, because you've sucked them in. But that's the way to find out. I also use GraphNet a lot now to look how many they've picked up and check. But that's 50% reliable. Half the patients who pick up all the medicines don't necessarily use it, and they sure as heck don't use it right. The other thing is check how they use it, because it's clear they've got no idea how to do it. They haven't done it recently.
It's a good technique. We had a kind of fairly specific question, quite interesting one. Is there any have you come across patients who have an allergy to Clenil and Seretide, and if and is there advice if we ever come across a patient like that?
I've definitely come across people who are intolerant of different inhaler types in a way that's really not very easy to explain. True allergy with an anaphylactic response, no, but definitely people who go, I suspect it's something to do with the propellant. And we've got the HFA 134 and the HFA, the different HFAs having very different global warming potentials, because some are worse than others. It's an absolute minefield. And, I could be here all day just doing the climate change stuff. But if they've got a problem with Seretide, switch them to Symbicort. If but actually dry powder usually if they're old. So it depends on the age. So it's quite a complex question. Yeah. You can usually achieve the same, but I've definitely had some where I've ended up, and I hate splitting the inhalers, having fluticasone and salmeterol separately. But I've had some where I've done it and they're fine with that, but they can't manage Seretide, and vice versa. They can't manage separates.
And so I think possibly then for the colleague, I don't know whether it's a question who's asking from primary care, sort of feels like any of those sorts of questions would be just contact your local pediatric respiratory specialist, just to get their advice on it, and don't worry about having to make that decision yourself in primary care. In my experience, you generally seem like a fairly approachable lot.
I mean, pediatricians, I spent my life trying to unlock the doors, saying, if you've got someone with difficult asthma, severe asthma, read mine and Mark Levy's paper about why a patient's still dying. It's like, seriously, because they're not referred. I would much rather see them, because if you've got patients who've got, missing time off school, having exacerbations, the threshold that is set, some of you guys out there in primary care, and definitely my secondary care colleagues, set bars that I would not accept that in my clinic. If there was a patient there, they'd be in my severe asthma service, years ago, and they're having lots of ongoing symptoms. So you go, no, just get them through the system. Our doors are always open. Mine are anyway.
Yeah, thanks for that, Will. I think that's a super important point, and one, again, from my experience in primary care, just to echo that, which is there is poorly controlled children with poorly controlled asthma should be referred. It's not, when we talk about the issue about severe asthma, we might end up thinking about children who need biologics, but actually a lot of these children with poor control, there are wider issues that are going on. They and it's not necessarily just children who need biologics to control their asthma who have poorly controlled asthma, and we should be referring these kids a lot earlier.
80-20 rule. 80% of the time it's adherence. It pretty much.
Yeah.
Sadly, I mean, not sadly, but it just happens to be the case. But it's that multi-component level of the adherence, because it's not just, are they taking it, but are they taking it correctly, and are they taking it correctly when you're not watching them? Because that's the final part of the jigsaw puzzle. Until we identify what people are actually doing in their homes when they're not being watched, and there's no point saying video yourself, because you do it right when you're being videoed. That's like saying, Oliver, tell me what you do in clinic. Not me sitting with my hidden camera and seeing what you do in clinic. And I ask everyone with a conscience to say, you might say you do it every time, but do you do it every time? And on that happy note, I'll leave you to address your consciences.
Thank you so much, Will. Really appreciate it. So apologies, I know there's so many more questions in the chat. We'll endeavour to have a look at those. Through the joy of Teams is that we can continue to add information into the Teams chat after the meeting. A huge thanks to Errol and to Will for joining us today, and to all of you for taking part, for your questions, and for being here and increasing your knowledge and awareness around asthma. Again, just a reminder, the Ask About Asthma campaign, really important. Lots of other resources that have been available over the course of this week. Would encourage you to access them and continue to share the message of the 3 important asks about asthma. Have you had an annual review? Have you had a review within the last year? Have you got a personalised asthma action plan? And has anyone shown you how to use your inhaler in the last 12 months? Thank you. With that, thanks again, and we hope to see you at events like this again in the future.